Hi, everyone. Today is December 10th, 2021, and it's a pleasure to have with us Jay Bhattacharya from Stanford University, where he's a professor in the School of Medicine, also in the Department of Economics, and a senior fellow of the Hoover Institution. Jay, thanks for joining us at UT.
My pleasure.
So I want to start by mentioning Hoover and the shirt that I'm using here, which is the saying of our Salem Center for Policy here, something that was inspired by Thomas Sowell, one of your colleagues at Stanford. And reminding everybody that I guess about a year or so ago, a little bit more now, the beginning of COVID, you were one of the few voices that were very strongly talking about the trade-offs that we're about to face with the policies being proposed and implemented in the country. So let's start from that. From that point. Let's start from back in March 2020, I think. That's when you first became, prominence around your work became very got emphasized, because you're questioning at that point in time the wise, whether or not the policies being put in place were wise. Take us back to that moment and walk us through what were you thinking. What was your thinking at that point in time in the beginning?
Sure. So in March of 2020, I had been following the track of the disease in China and in Italy, there seemed to be like still a great bit of uncertainty about how widespread the disease was. I'd remembered back in the H1N1 2009 epidemic, there was a lot of evidence that early on that people were very scared about the high case fatality rate, because they were looking at the number of deaths divided by the number of identified cases. But then over time, over the course of a couple of years, it turned out, based on seroprevalence studies, that H1N1 was way more widespread than people had realized. A lot of people got infected, recovered, and had very few symptoms. And so the infection fatality rate turned out to be much, much lower in H1N1 than the case fatality rate, 100 times lower, 99.99% survival, something like that on that order. So I had hypothesis that might be the case in the context of COVID. At the same time, I'm a health economist. With that slogan you have on your shirt, that is true in health economics to spades. Every action here that people were talking about or potentially contemplating was going to have consequences, and it wasn't clear to me that those consequences should be ignored. I remember a reporter from Reuters called me up and asked me, I think it was mid-March or right around when the lockdowns were starting to get implemented, about whether I thought, he was asking me about like domestic abuse and child abuse. And he was asking me what would happen if everyone were to stay at home, what would happen to child abuse and domestic abuse. And actually it struck me that he was asking me this because it seemed like everyone else around the country was just panicking around COVID, and he was thinking about child abuse. It was very clear to me then, and it's what's happened, is that children were going to be abused. Normally, you pick up when schools close. What happens is children, that the abuse of children gets picked up at school, where there are people to see the bruises and then call Child Protective Services. If you keep kids at home, those kids don't get picked up. They just get abused. Same thing with domestic abuse. I could see also the psychological harm to so many people from this kind of isolation. Lockdown is a prison term. It's designed for punishment. And in July of 2020, the CDC found 1 in 4 young adults had seriously considered suicide. And the other thought that I had in March 2020 was to the world's poor, right? So you have 20 years or more of globalization, where poor countries around the world have reorganized their economic life to fit in with the world economy. That means so many people's lives, including poor people, had been changed so that they could fit in. They could do productive things that would work, that would allow them livings. And 1 billion people were lifted out of poverty as a result. Lockdown, it seemed to me, was guaranteed to reverse that. And that's what's happened, right? 100 million people thrown into poverty around the world because of the economic dislocations caused by lockdowns. 80 million people, these are all just UN numbers. 80 million people thrown into dire food insecurity. hundreds of thousands of children dead from starvation in just South Asia alone. I mean, I think these were entirely predictable. And many people actually were predicting them. Like the UN was yelling from the top of his lungs, these are going to happen. These things, we're going to stop doing malaria control. You're going to stop doing treatments for TB. It was you're going to have crazy reductions in immunization of children with long-term consequences. You stop checking cancer patients for early stage cancer, so you end up with late stage cancer later. So women coming in late stage breast cancer that should have been picked up last year. All of these things were entirely predictable as costs of the policy. So that's what I was thinking in March 2020. Right? I was thinking that we don't know yet how deadly the disease is until we've done some detailed seroprevalence work, and but we know for certain that the harms of these lockdowns are going to be devastating.
So you're there sitting as an economist thinking that this action will have tremendous potential impact, which is, again, any reasonable person at that point in time would agree that an extreme measure of asking people to lock in place for an indeterminate period of time would have severe consequences. I mean, I remember being concerned about, I don't know what that does to a supply chain. I don't know whether we're going to have, disruption of food supplies and people. And I'm actually was very pleased to see that somehow even though we're complaining a lot about supply disruption of things right now, the grocery stores are packed and stocked with things. And, even in the height of the problem,
I'll tell you why that
I was shocked by that.
Well, I'll tell you why, right? So the lockdown essentially was a policy designed to protect the rich. It's a policy designed for people who wouldn't lose their jobs, and they could replace them with Zoom if they didn't go into the office. We designated a large part of the population as essential, right? The people who grow the food, who stock the supermarkets, who bring the food back and forth, who make sure the electrical lines work, make sure the internet works, make sure that the garbage is picked up. All of those people, they didn't lock down. How could they? Because they actually are essential to our normal everyday life. The working class is incredibly important to regular everyday life. We locked down to protect a certain class of people, the rich, right? The laptop class. It was a luxury of the rich. And you can see this in poor countries. Peru had a military style lockdown that was unlike anything else in the rest of the world. It resulted in countless poor people dying from things other than COVID, right? Starvation. And it
didn't stop COVID either. And it
didn't stop COVID either, right? And so that's the thing. Like, people thought about lockdowns as a magic bullet because, look, I can't spread the disease to you if we're apart from each other. But that's not the reality of lockdown. The reality of lockdown is a certain class of people is protected, and the rest of society is exposed.
Yeah, I'm from Brazil originally, and I remember thinking about if you've ever been to a slum in Brazil, or to taking a bus in a poor neighborhood in Brazil, which I have, and the notion that, oh no, people are going to just stay home and that's going to solve the problem. Well, home is much more crowded. Those places are very crowded, and you know what? There's no way that's not going to just rip through a neighborhood. Which, again, the world got a little bit more dangerous once the virus came along. There's a new pathogen against humans, and it just worked, right? They're really good at going around.
Yeah.
And I mean, the notion that we're able to stop it through asking people to go home in poor countries, it was just unbelievably naive. And maybe good for university professors like you and me, but not for most of the people in the world, right? So let me go back to the seroprevalence studies. That then you were in the first ones to try to get information on that. How many people basically try to look for prevalence of antibodies in people's bloods, so that to see how many people got exposed already in the early days. So I think you got out with a study in was Los Angeles and somewhere in the Bay Area. Is that right?
Yeah. So the Santa Clara County and then LA County.
And what was the main finding then?
Right. So we did these studies in early April of 2020. And as you said, what we did is we got populations, like samples from the population, community dwelling populations, both places, where we looked for antibodies specific to SARS-CoV-2 virus, the virus that causes COVID, And what we found is that there were 50 times more infections than between 40 and 50 times more infections than cases. We weren't testing a ton back then. And so it's in some sense not surprising. This is a respiratory virus that spreads very rapidly, very easily, which we know now by aerosols and droplets and things. The fact that we weren't picking up infections is not that surprising, especially since most infections result in relatively mild disease. The severe disease outcomes that we see, the viral pneumonia we see, that's a small subset of cases. It turns out we didn't know that until we did the study, and so there's a few things that we found. So one is that the prevalence in California, in the big big regions of California like Bay Area and LA, was something like 3 or 4% of the population in April of 2020. And now that doesn't seem like a big number. In one sense, it's not. That means there's a very large fraction of the population still susceptible to the disease. I mean, so in a sense, it predicted that this was going to be a long epidemic. On the other sense, it's actually a pretty large number, right? 3 or 4%. The disease, like the start date in the U.S. was supposedly January 2020, late January 2020. In just 2 or 3 months, we'd gotten to 4% of the population had infected undetected in LA. I mean, that's a pretty large number, actually. And what it meant is that the kind of idea that we had, which was like, let's just test everybody, isolate them, and then contact trace, and that'll stop
out of the bag already, right? Yeah,
could not have worked. It was, we knew that from the 4. If it was 0.4%, maybe, but even then it'd be difficult because the disease, you can spread it even if you don't have very many symptoms. And then so that we knew from that. And then the third thing we learned from that is that the infection fatality rate for the community dwelling population, at least, was the survival is like 99.8%, 0.2% infection fatality rate. We also saw in it a steep age gradient that's actually is the most important fact about the disease. Older people have 1,000 times or more likelihood of dying if they get infected than younger people.
So from the very beginning, you could see that the parameters being set in some of the epidemiology models that were predicting millions and millions of deaths in the US, for example, were just not necessarily within the sort of acceptable range.
Yeah, I mean, I think
the number of people that were already infected and the implied infection fatality rate at that point.
Correct. Yeah. So I think the infection fatality rate assumed by the Imperial College model for the US was like 0.9%. Which is off by a factor of 4.5. The millions of deaths predicted. It was interesting. Those models were predicting if you did nothing, millions would die within months.
Right.
I mean, I think what I'd hoped was that people that were populating those parameters of those models would update based on this, and some did, but for the large part, it sort of that didn't happen.
In fact, there was a lot of like folks attacking your study and trying to poke holes in it, and not necessarily try to see what the message really was out of that study, but rather try to say, oh, this is just try to portray you as somehow a, I don't know, propagandist or a Trump supporter that wanted to somehow, fight the lockdowns or whatever. And that tell us a little bit about that, because I remember having a lot of reading a lot of criticism that were just
I mean, I think like I have mixed feelings about it. Like I think some of the discussion was actually quite productive, but some of it was just nasty and counterproductive and a lot of it I think stemmed from the desire not to believe the result. Let me start with the good. So one of the first criticisms I saw was like by I forget the name of this guy on Twitter. Who said that, look, if there's a possibility, so we used a test kit that checked for the antibodies in your blood, right? But every medical test has some errors, false positive errors and false negative errors. And we had 3,000 people that we checked in Santa Clara County, 50 of whom were positive. And the reason we got the 3% is you have to adjust for the demographics of the population. That's the way we did the sampling. But anyways, like the raw number is 50 positives, 3,000 people. And what he said was, look, given what we know about the test kit they're using, the false positive rate that the manufacturer reported was 99. Well, the false positive rate was 0.5%. That means that there's some possibility that all 50
False positive.
positives were false positives. Now, it turns out we actually had a formula to adjust for that, for the observed false positive rate. And it also, you have to account for the false negative rate, because the false negative rate is like was 10% or something on that order, 10-15%. So you have to adjust for both simultaneously, and the estimates that we reported were correct. Were correct for those false positive, false negative. But there was a big fight over the standard error around this. And the key thing to the standard error is how confident are you that false positive rate is 0.5%? So the manufacturer had done, the way you check for that is you say, okay, let's use blood from 2018, we know is negative, run it against the test kit, and if there's any positives, it must be false. Right. That's what the manufacturer done, something like that. And it turned out that they had like 400 samples, and 4 of them were, I mean, it was a very, very, very small number. Like it was 2 of them were, I mean, I forget exactly the numbers, but it was a very small number of false positives. But that's only 400 samples. That actually leaves quite a bit of wide standard error still, contributed by the sampling error in the false positive rate measurement. It's like a little bit statistically complicated, but so what we when we released the study on medRxiv, this open access sort of preprint server, Twitter exploded. I got 1,000 referee reports overnight. It was anyone who's ever had 3 referee reports to deal with can understand my anxiety. But like constructive things started happening. People started giving us, it turns out labs around the world were evaluating this test kit, and they sent us their evaluations. And we went from having 400 evaluations of this test kit to having 3,000 or more evaluations of this test kit for the false positive rate. And it turned out the manufacturers were right. It was like 0.5%, even after 3,000. And that tightened the standard errors. So we released a second version with sort of tighter standard errors. But people still don't believe it, right? A lot of people, including some very bright people, were convinced that there was very low prevalence, maybe 0. And they were fought very hard to maintain that on the left edge of the confidence interval, that you could have had 0 prevalence. Right. The thing was that, like, it just seemed like nonsense. 1,000 people had already gotten the disease in Santa Clara County in April of 2020, like a case.
The positive cases, exactly. Yeah.
And so there was no reasonable sort of Bayesian prior that leads you to say, okay, you might be 0. I mean, that's just, if you did that, then you're falsified by just the basic observation of the data.
But wasn't already motivated reasoning at that point, because there were so many people committed to the ideas of the policies being put forward that they couldn't. I mean, your statements at that point say, listen, these policies are not going to necessarily work out. The prevalence is high already. It's not as bad as you're saying from the models that are justifying the lockdown. But if they dug their heels in and say, oh, no, this has to be true because we know the answer.
And it was like middle of April 2020 when we released it. We already had a month of lockdown. And it already started to produce some of the catastrophic effects we were talking about. And so if we lock down for nothing, well, I mean, a lot of very smart people have egg on their face then, right? You do one of 2 things. You can say, okay, well, here's what the data say. Let's alter our strategy on the basis of it. It could even be reasonable to say, look, it's only 1 study. Why don't we look for more studies? Right? Well, let's rapidly do an incredible number of these seroprevalence studies, and then take those studies together and see what happens before we like adjust our policy. I mean, that I think would have been a reasonable thing. But instead, what happened was a lot of very bright people essentially closed their minds to the possibility that the disease had already spread so widely. And it's there were actually some seroprevalence studies that were done around the world. Hundreds of them actually were done. And when you do like Johnny Ioannidis did an analysis, a meta-analysis of them, and the median infection fatality rate was something like 0.2% worldwide, especially in younger populations. Now, in places that have older populations, you have a much higher infection fatality rate, right? So New York City, which exposed all these poor folks living in nursing homes they had a much higher infection fatality rate. Why? Because the set of people exposed, they didn't protect the vulnerable, they didn't protect the old. So that's why they had such a high infection fatality rate early in the disease. Whereas Africa, for instance, where less than 3% of the population is over the age of 65, has had a very low infection fatality rate. Worldwide is 0.2%. If you want to know what the infection fatality rate was in Santa Clara County in 2020 or early 2020 in a community dwelling population, I mean, where else are you going to look? We're the only ones that did a measurement there. The fact that the CDC, the US CDC, has not followed up with systematic seroprevalence studies continuously so that we can have an understanding of how widespread immunity is in the population is baffling to me.
Right. I mean, exactly. I think that there was a focusing on estimating precisely the infection fatality rate became again somehow a questioning of the policies in place. And at some point, it became no longer about that. You know, you don't need to justify the policies based on the severity of the disease and how many people it kills, really, but rather it became this thing about cases and you know, because it was no longer judicious, right, for them to be focusing on that, right? Because at the end, I think you and your needs have been vindicated on the IFR here. In fact, if anything, the IFR keeps going down, down, and down, given our ability to treat and so on, right?
Yeah. I mean, I think it's really the policy that's still like so it has me shocked. Like again, if you don't agree with the estimates we did, fine, but you really should want to know how widespread the disease is, and the only real tool we have for that is these seroprevalence studies. Why did the CDC? They still don't have systematic seroprevalence studies that are tracking for representative populations. India has better ones than the U.S. does. Lots and lots of other countries have much better tracking of these kinds of basic stats than we do.
So one premise of a lot of the models that were being put forward to justify the policies in place was that there's nothing that we can do. There's a lot of susceptibility in the population. This thing's going to grow exponentially. And it's going to have a peak, and then it's going to come down. I mean, all those models, all of them, I looked at, I think almost all of them would predict one peak. They would just go up exponentially, and would all of them predicted that would outpace our capacity to handle people sick, and therefore we need to do something really, really strong right now to flatten the curve. That's what the way they phrase this thing, right? And at first it was 2 weeks, but 2 weeks became 2 months and became 6 months. In some places became like nonstop, right? But what was very clear, well, that's not very clear. So I remember kind of buying into the notion that, okay, these models are not necessarily bad descriptions of the world, but they might have bad parameters. And in the beginning of it, I was reading your work and other folks thinking maybe it's just a matter of the parameters being wrong. And what we're seeing in reality is not as bad as what those models are predicting, but it's going to go up and down. So when things start happening in Texas, I remember, so Texas, we did a 6 weeks, a very short, I think, lockdown and late March, early in April. And then by May 1st, 2020, Texas kind of came back to normal. And, you know, we had a little bleep of disease here. We haven't had a big impact yet. And then, summer I think was maybe after Memorial Day, things start happening and we get our first flare up, our first wave, which was a bad wave that killed a lot of people. And I was thinking at that point in time that, well, this wave is going to come and it's going to go just like a lot of those models are predicting. And then we're done with it. It's just a matter of how tall that peak is going to be. Even that wave, as severe as it was and as stressful as it was, and I'm sure it was very stressful for doctors and nurses working in places, it was not overwhelming to a point that said, okay, our hospital, we stopped caring for people. And I don't think we faced really that in almost anywhere in the US, maybe very small situations where that took place. But then talking to you around the same time, you made a comment of to me that I think was something that, I never thought about before. You said, well, people are misinterpreting what herd immunity means. They keep talking about herd immunity being, okay, we're going to reach this point where there's people start infecting less than one person, but less than one on average. And therefore this thing's going to come down. And I thought, yeah, we're going to turn down and then we're going to be over. You said herd immunity is environmental. It depends on the conditions. And lo and behold, the fall comes along and, up we go again, right? We got to herd immunity, but it's not fixed. It's not a fixed thing. And we kept seeing this now. We keep seeing this going over and over and over again. And none of the models were saying that to us in the beginning. None of the models that justify lockdown were told us, listen, this is going to be an endless set of waves because that's it.
Yeah.
And I think that would be very hard to justify what we did if they were saying basically that, like, listen, there'll be waves and they're going to come and they're going to come again and come again and come again, right? And I think in your thinking in the Great Barrington Declaration and the sort of like focusing on protecting the vulnerable, that was part of the thinking, right?
Yeah, I mean, it's absolutely part of the thinking. I mean, this is very clearly a seasonal and regional disease. Some regions get hit for certain seasons. So for instance, New Zealand and Australia were hit in March 2020 during their summer, during low COVID season, which explains why they were able to get the cases so low for extended periods of time with the lockdown. And of course, they're islands. The thing about the way this disease is, the best model really is to look at the other coronaviruses. There is herd immunity to the other coronaviruses, but the way it works is complicated. The threshold for herd immunity is high during the high COVID season and low during low COVID season. So you need a larger fraction of the population immune during the high season for the disease not to spread, and you need a lower fraction immune during the low season for it not to spread. The immunity of this, once you're infected and you're recovered, and we now know from like extensive data from like excellent studies out of like Qatar, Israel, a whole bunch of other places, that at 1 year, the reinfection rate is somewhere between 0.3 and 1%. So if you get infected and you recover, only about 1% of the time will you be reinfected within a year. And when you get reinfected, it's much milder. But if you get reinfected, you can still spread the disease, right? And so like and then the vaccine also provides for a limited time, some protection against infection. Ironically, it's only a few months, maybe 3-4 months that it provides any substantial protection against reinfection. By 6 months, it's like 20% efficacy against infections.
But still protects against severe disease.
Yeah, still protects against severe disease. The vaccine is very worthwhile for that. I mean, that's what, in fact, it's a perfect tool for focused protection, right. Much less good for herd immunity. And so you're going to get these waves. You're going to get, if you get, and when you had a completely immune naive population like we did in March 2020, you're going to get a massive wave, almost no matter what you do. We had this illusion of control that the lockdown will stop the spread of the disease. It didn't actually succeed at doing that, obviously. And it was very odd to see public health officials attribute to their actions the rise and fall of the disease. Then you see like someone like Tony Fauci go on the air saying, "Oh, I don't know why it went down in Texas when they didn't do very much. Oh, I don't know why it went down in Florida, why they didn't do it very much." It's just a mystery to me. I mean, it was as if they thought they could control the where the ocean went. Right. That's the hubris is still shocking to me.
And the hubris is still there. I mean, it's still this whether it's masks, whether it is statements of social distancing, statements like the things about travel restrictions. It's like, what are we hoping to accomplish with this? I'm going to visit my family in Brazil next week, and me and my 2 kids and my wife, we all have to test before we go, and we're all vaccinated. We have to test before we come back. I was like, what are we really hoping to accomplish? Not infecting.
I mean, I think like if you're not sick, just what's the purpose of the testing? You're all vaccinated. I mean, so you don't face any undue risk.
And there's disease there, and there's disease here. So it's not like, we're not trying to stop the disease transport between one country and the other. It's just like, this is happening everywhere. It's endemic everywhere, essentially. So
and so I think that's just it, Carlos. I mean, we have to accept that the disease is here to stay. And then the question is, how do we manage that risk? And that was the idea of the Great Barrington Declaration. How do you manage that risk, given that we don't have a technology to stop the disease from spreading?
Right.
What we do have is, now at the time in October 2020, we didn't have the
vaccines either. That's right.
But we did have was, knowledge of who was most vulnerable. And so there you could say, look, in the places where most vulnerable people are, let's try to reduce the risk of spread there, since it's not possible in the population at large, right? So just a very simple thing. If you understand that the key constraint is the protection of older vulnerable people, then you would never send an old vulnerable COVID infected patients back to a nursing home, right, in order to save a hospital bed. The mistake was they didn't understand what the key constraint was. The key constraint was protection of the vulnerable, not keeping hospital beds open. They optimized against the wrong thing. But there were lots of other, that's a negative thing to do. But there's also like other positive things one could have done. Like, so we could have offered free home delivery of groceries to every single older person in the United States, right? That's a very simple thing. That way they don't have to go out and get groceries. It'd be exposed potentially. We could have, there's something that many places did do with sort of varying degrees of success, is doing better with nursing homes, protecting nursing homes, reducing staff rotations, a whole bunch of things. I mean, the thing is like what I expected with the Great Barrington Declaration was that local public health would join in trying to use creative ways to think about how to protect the vulnerable within their own communities. Because it really depends on the living circumstances of the vulnerable people. It's going to differ from place to what the right solution in Brazil will be very different than the right solution in LA County or Santa Clara County. And local public health is in much better position than I am to like dictate for the entire world how to do that. But just to say that the only way to protect the vulnerable is to stop community spread, I mean, that effectively is just saying I'd give up, because we don't know how to stop community spread. We don't have a technology to stop community spread.
And I love the sort of paradox between this incredibly blunt instrument of the solution is lockdown, and they kept emphasizing that. And I think every not public health, but every epidemiologist that I've talked to, I saw speaking, was always emphasizing, no, we need to do more lockdowns and more putting people away, and so on. And then somehow buying into the panacea of masks. It's like, really, cloth masks? That's I mean, I can see the mechanism which might be helpful and reduce things, but like that is not as.
Carlos, even there, so they're like in March 2020, there was a large literature and well-developed literature on masks on the spread of the flu.
Right.
And with good randomized studies, dozens of them. And the conclusion was that masks do not stop the spread of the flu. With like the exception of like if you're wearing N95,
right,
and you're trained, you're in a hospital, then maybe you have some effect. But like cloth masks, no. Even surgical masks, no. And the reason is very simple, mechanically, right? So the flu is spread by aerosols. Aerosols are like clouds, droplets like rain. They hang around, all right, in the room, and so like filtration systems might remove them. But if you have a stagnant air, you're breathing out if you've ever worn glasses and worn a mask, your glasses get fogged up. That's the aerosol coming out, and they come out the sides. So no matter how well the mask does in filtering out the air that comes out that back and forth, there's still escape out the sides and back. It sits in the air and then it spreads.
Right, and I think, but people have this idea somehow is linear, right? That because some of it might be trapped here, therefore it's going to help, and it's not linear. It's a threshold situation, right? Where enough comes out, there's enough hanging around, you're going to pass it on, right?
But so now once we knew it was aerosolized, which we suspected very early on, then that lends itself to much different set of interventions, right? So then what you do is you upgrade filtration systems in public spaces. We spent $6 trillion. How much did we actually spend on that? I mean, it's like vanishingly low. And instead of like recommending a solution that really isn't a solution, where large amounts of experience through decades have found that it is not particularly effective, these masks, and it had become politically divisive.
Right. Oh, right? I guess you see the best example of the effectiveness of the air filtration system is the airplanes. Nobody gets COVID in airplanes. It's an incredibly tight space. There's those are not super spreaders ever. We hear anything about airplanes because they have a very effective filtration system, right?
Yeah. The other one is outside. Like very, very rarely do you get outdoor transmission, right? Because nature has provided us a fantastic filtration system. So, I think it is like absolutely shocking. Like we landed on a solution with almost no evidence. Certainly no good evidence that it works, and it's politically divisive. It's created this talismanic division between people, where like it's essentially a matter of faith. Does it work or not work?
Right.
And instead of effective things that we knew could work,
we gave up on it. So let's talk about now. Just we are in the midst of Omicron as our new, again, the stoking fears in the media and everywhere is that somehow this is going to come back again. It's going to be 10 times more infectious, and here we are again. So what are your thoughts on where we are in terms of this current wave and what happens next?
Yeah. So this is an RNA virus. RNA viruses, whenever they replicate, they get errors and mutate. Most of the time, those mutations disable do nothing to the virus or disable it. Or very occasionally, you'll come up with a random mutation that has some selective advantage in the environment it sees. I mean, the theory is that at least the preliminary evidence is that Omicron it has some mild selective advantage. It seems like it's more infectious than the Delta, which it seems to be starting to replace. Although Delta is still the predominant variant worldwide. That is going to happen over and over again, right? That is the nature of these RNA viruses. We are going to see forever a new variants. I mean, we'll have to come up with some nomenclature after we reach Omega or something.
Double Delta, you know, something like that. Yeah.
Yeah. Well, alpha squared or something. I don't know.
Yeah.
So I don't think that. I think that. Like if the media and public health panic every time there's a new variant, we're going to be panicked ad infinitum into forever. So the question isn't whether the presence of a new variant that's starting to spread is something to I mean, that's not the thing to worry about. The thing to worry about is, does the variant escape prior natural immunity produced by prior infection? Does the variant escape protection against severe disease provided by the vaccines? That's it. That's the only thing to worry about. Does it produce more severe disease?
And so far we have little evidence of that, right?
Yeah. So far, I'm not. Obviously we should still like be careful.
It's possible.
Yeah, it's possible. Like it's because I mean I think many of the people that have been infected have been younger people, so they're likely to have mild disease anyways. So I haven't seen age-adjusted mortality. Certainly I haven't seen infection fatality rates with zero prevalence backed up around it for the mortality rate of Omicron. So we'll see. But I mean right now the news looks hopeful. It's in some sense not surprising. Like the sequence of variants it seemed like they've been tending in the direction of less severe, and it might evade infection blocking immunity. So if you had the vaccine, you can get infected, but it doesn't seem like it's evading the protection against severe disease. That was true, I think, for the Delta. It was true for Alpha. It was, I mean, the immune evasion. Which a lot of the data about immune evasion comes from like studies in vitro to see if it produces like antibody, like are you producing antibodies to the new strain? But that's not enough to suggest that you don't have protection against severe disease, even if the antibody production is lower or the antibody neutralization is lower, or whatever. What you need is empirical data about how does it actually, what actually happens when people actually are infected with it. How likely is it, given their age, that they end up in the hospital or they die? I think like the public health messaging around this needs to change fundamentally, right? It cannot be the case that every time there's a variant, we panic the population into doing useless things that didn't actually work before and have incredible harm. Right, it's a lot of the policy malfunction comes from essentially the recollection of the fear that we had in March of 2020. Right. Let's tap back into that over and over again. It's a recipe for continuing these lockdown harms without actually doing much for stopping the harm from the virus.
Or at least I feel that in the U.S. so far we have not tried to double down on some bad policies, at least so far. Which is, I mean, Europe is screwed back, right?
Oh, well, yeah, Europe has gone, I mean, like they've gone into these vaccine passports, this militarized biosecurity state kind of response.
No, and lockdowns again. I mean, schools are closed in some countries right now.
I think I mean, it's one of these things where like it's the countries that were praised the highest for their ability to stop the virus.
Yes.
I mean, it's kind of, they put themselves in a policy cul-de-sac. because there's no policy that stops the virus. We have no technology to stop the virus. And now every time the virus, so like New Zealand and Australia are perfect examples. They've actually been quite successful at vaccinating the population. They could open up and they have about as good protection as anywhere else does. But they keep locking down. Like I heard in Northern Australia that they had opened up a concentration camp for contacts of people who were infected, and even for people who had the disease. I mean, essentially, like wide scale violations of civil liberties, and in order to stop the virus from spreading. The virus is still spreading. I actually in Australia and New Zealand, I predict that the virus will slow down, and you'll have less spreading. Why? Because their summer is coming.
Right. That's right. The seasonal component of it is gonna trump this, right?
Yeah.
So let's go back to the academy. I mean, it seems that a lot of what happened in terms of was like it's not what is it, like a herd mentality type problem, where there was one solution, there was one thing that people thought that's the only way to think about this problem, and anybody and that's maybe fine that everybody goes into one direction and stop thinking about, critically about other potential opportunities to understand the situation in front of you and make different decisions. But what's really scary is that when a few start saying, wait a second, maybe there's a different way to look at this. Maybe there's other things we need to consider. Maybe there's other alternatives to what we're facing here. It seems that we found ourselves in a perfect storm where that became like religion, where you couldn't question things. You couldn't ask questions. You couldn't propose alternative solutions. And if you did, you're going to start being attacked very severely. I mean, I suffer a little bit of this, but nothing of the scale that you did during the last year or so. So starting from your study, there was a lot of perhaps, you mentioned the positive criticism, but there was a lot of ad hominem. There was a lot of direct attacks on you at that point in the very early days of April. And then after the Great Barrington Declaration, it became, that was a different level, right? Of scrutiny on your statements and so on. So why? What about our system? What about the scholarly procedure that we have these days that sort of lent itself to that? What's your take on it?
I mean, I think the reaction of the scientific community and the policy community to the virus has exposed deep problems within science itself. Right? I think that science, I actually have been working on science policy before the pandemic. Like one of the findings from my work before was that science had become much more conservative in its willingness to explore new ideas. And they've done a series of studies to try to show that, for instance, the NIH was funding like older and older ideas over the last, over time and we started to reward scientists based on influence, like how many citations you have, rather than trying new ideas. I mean, you had like this two worlds. Like in VC world, you have, try new things out. If it's failed, that's fine. Failure is actually a route to like learning, so you have more success later, right? Whereas in science, we've gotten to this point where like, if you shouldn't be trying, if you try brand new ideas out, you're gonna get pummeled, right? Because like I said on NIH review panels, where I see this all the time in NIH review panels, every time there's a proposal with something that's like a little bit out there, because the author or the investigator is thinking in a way different than the scientific literature. Although you're supposed to reward innovation, what happened routinely is the reviewers would just pound on it, say, this couldn't possibly work. And reviewers, of course, have an invested interest in the existing sort of paradigm just to not be challenged. Of course, science requires that kind of challenge, regular upheaval. It requires being open-minded to the possibility that the way I think about the world is not the truth, and that we've discovered a new way of a new set of like experiments that lead you a different direction.
Which makes the statement follow the science particularly problematic, right?
Yeah, I mean, science is exactly. It's like science is it should be, when it's functioning well, is a dialectical process. I believe A, you believe B. We
Try to gather evidence and yep.
Yeah, look, we devise an experiment to decide between us. It turns out that B is right. I mean, like, I go, oh man, and I buy you dinner, and then I say, no, not B, C, and then we move from that, right? What happened in science is instead a sort of like a high priesthood. I mean, you brought up the analogy of religion. Frankly, I'm Christian, and there's much more free discussion about Christianity within the church than there is in science, I think, in some sense. So like you have someone like Tony Fauci, he gets up there and says I am the science. I mean, he effectively is saying he's the high priest of science. He's the Pope. There is no Pope in science. There is nobody who has the authority to say, this is true and that you shall not challenge me. And actually, there are concrete policy reasons why I think this has happened. So like take Tony Fauci, for instance. He's in charge of a vast amount of money that funds the work of very prominent epidemiologists, immunologists, virologists within the scientific community focused on infectious disease. If they step out of line, in that case, what I mean by step out of line in this sense is like they don't follow the priorities of the National Institute of Health, the part of the National Institute of Health then their likelihood of getting grants is going to get lower.
Yeah, right.
Their likelihood of getting, and if they don't get the grants, they can't publish. They can't. Then that means that they can't get grants. It feeds on itself. It's central to their careers that they figure out what the NIH wants and then work to give it to them. At the same time, you have Tony Fauci, who's in charge of COVID policy. It's not that much of a stretch to understand why so many scientists stayed silent, even if they thought that these policies were a mistake. Their careers were at risk. You've created this conflict of interest by putting the same person in charge of scientific funding as COVID policy.
Right.
And this happened with, for instance, the Jeremy Farrar and the Wellcome Trust in the UK, Bill Gates, same thing, right? You had these people who were incredibly influential on COVID policy who were also funding science. There needs to be a wall of separation between policy and scientific. The same people shouldn't be in charge of both, because you create this like conflict of interest. And on top of that, you have this environment where like science has moved from this norm of free discussion. I mean, it follows the cultural. I mean, I think the culture has moved this way as well. Like somehow you've moralized the discussion so that if I believe A and it's out of line, it's not just that I believe A and I'm wrong. I'm evil,
right?
For some sets of propositions that were A, and a lot of like the COVID discussion came around that. If you believe that lockdowns won't work, well, that means that you must be in favor of of like letting the disease spread. All you care about is money. You're evil. And a lot of the smearing, and scientists were subject to this too. Like that, a lot of scientists engaged in this sort of smearing. I don't know how many emails. I wrote an op-ed in March of 2020 saying that we don't yet know how widespread the disease is and what the infection fatality rate is. And I got emails from, I thought friends at the university asking me why I care about money so much. I mean, I didn't get money paid for that op-ed. I'm a health economist because I care about the vulnerable, right? That's why I spent my career. Money is not the reason. I don't believe that optimization of society means maximizing the total amount of money. I believe it means providing opportunities for well-being for as much as possible, given that there are no solutions, only trade-offs. Right? I think it's always like, how do you manage those trade-offs? How do you expand the pie? I mean, that's what economics and health economics has always been about to me.
But let me submit a proposal here of an idea why this happened as well. Our institutions of our scientific institutions and our universities have slowly and but surely developed into a monoculture that is very left-leaning, very, very left-leaning. And one of the characteristics of the left is the sort of like not accepting the idea of a budget constraint. You don't accept the idea of a budget constraint, you don't think there are trade-offs. And I think that's just the sort of like, yes, lockdown. What is the trade-offs? What is a big deal? And that becomes the sort of, again, the monoculture that, yes, that's it, no problem. Even amongst economists, there was a sort of like, no, it's okay. It's fine. It's not, the cost's not going to be too high. And you start finding like arguments to the extent of like, no, but the cost of even if you don't lock down officially, people are not going to go out. So the policy are not doing much. That's what it is. And there's no effect of the policy in place and so on. I wonder how much of that it has to do with the monoculture, because you mentioned the monoculture, the funding connections and so on the between the funding and the people potentially in charge of policy. But within our universities, how much of that is the sort of monoculture that has been created already?
I mean, I think the monoculture either on the left or right is a problem. Right. I mean, I think like vigorous debates between left-leaning professors and right-leaning professors about whether something really is a constraint really productive.
That's important, right?
Yeah, and I think the key thing is the moralization and demonization of moralization of the debate and the demonization of opposing ideas that comes and is permitted when there is a monoculture. Like if a professor, a left-leaning professor, has never really engaged seriously with someone on the right, and they have this caricature of what someone on the right really is that doesn't actually match reality, it's very easy to demonize them.
Right.
I mean, I personally never signed up for a political party and still haven't, because I wanted to. I'm in public health. I'm in health economics. I figured I would have results that would sometimes make the right happy, sometimes make the left happy. I honestly can't predict where
ahead of time, right?
Yeah. I just can't. And so I figured I want to be able to communicate the results to anybody without having this politics get in the way of this, where people like judge me based on my politics. I mean, ironically, like, because during the course of the pandemic, people have judged me based on what they assume to be my politics, where they don't really know what my politics are. Why? Because it's so easy to demoralize the other if you are in a monoculture, to demonize the other if you are in a monoculture. And so, weirdly enough, the left, which had produced this like discourse of let's not demonize the other, have in fact engaged in demonizing the other, where the other is people people that don't agree with them, people on the right.
So anything particular to you at Stanford that happened during this time? Was Stanford supportive of your efforts, or just like not really? Was it antagonistic to your efforts?
I mean, during the Santa Clara study days, Stanford was actively hostile. They actively worked to suppress my academic freedom in ways that I'm going to try to write and talk more about it. I mostly have avoided talking about it because I didn't have the emotional bandwidth to both fight a fight about academic freedom at Stanford while also fighting a major fight over the lockdowns. But I want to turn my attention to it. I do believe that the universities play a fundamentally important role in discourse in society, in our society, and it's right now they're playing a poisoning role. And I want to turn my attention to that as the lockdowns. I mean, I think as the consensus is starting to emerge that the lockdowns were destructive without actually having stopped the disease from spreading. I mean, I think that I can in good conscience turn toward the academic freedom fight. Stanford acted in ways in ad hoc ways to suppress the results from the Santa Clara, to aid and abet the demonization of the study authors, including me and John Ioannidis, and in general has done almost everything it can to not live up to its ideals of academic freedom during this last 2 years. And it's a source of great sadness to me. I've been at Stanford for 35 years. I mean, I arrived when I was 18. I've always thought of it as a place of freedom. The motto is "Let the winds of freedom blow" in German, which I can't pronounce. And I've loved that. And for most of my career, it's felt like that. The last 2 years, especially, I mean, my eyes have been open to an undercurrent within the university. With the university leadership doing almost nothing to change, in fact, aiding and abetting it to suppress the free exchange of ideas.
Yeah, you mentioned you and Ioannidis. I think Scott Atlas was another one that at Stanford as well. They got I think was it a Stanford Senate or faculty Senate resolution to try to do something against. I don't know if you were involved in that, but I think for sure Atlas once.
No, that was, yeah, that was Scott. They attacked Scott because they didn't like that he was working for Trump.
Right, but the fact that
the substance of their arguments against him were nonsense. They said he wasn't in favor of hand washing. Well, that's just a lie. I mean, I think the fact that they don't agree with him about the science of masks. Well, I tell you what, Scott knows more about the science of masking than the typical member of the faculty senate voting. For me personally, there was a petition floated around by some epidemiology professors trying to get the university president to silence me because I said that there were no randomized trials showing that masks worked in children, which is true. It's just a true fact. The way that disagreements should be dealt with, there's a constructive way and a destructive way. The constructive way is open debate and open discussion, tolerance for the opposing views, even if you disagree. The destructive way is this sort of like sneaking around, circulating secret petitions or getting petitions to try to silence and denounce. Those are not tactics of a confident group of people who are confident about the intellectual position that they hold. Those are the tactics of a group of people that will not defend their position openly with arguments and facts. Because, I might be wrong about something. And frankly, if I'm wrong about something, you show me facts, show me the evidence, I'm happy to change my mind because now I've learned something new. This is the argument that John Stuart Mill made for free speech, right? So if I say something wrong, well, and you have the right idea, well, I've actually given you a blessing. I've given you the opportunity to correct me so that you yourself can be more confident because it's been challenged by a wrong idea. Now you have a better argument why you were right, or alternatively, maybe you'll be corrected, which is actually also good for you. I mean, that notion of tolerance and in humility is absolutely central to like true academic freedom. And what we have instead is this atmosphere of demonization of the other, this repulsion, this idea that even having a debate at all is dangerous. Well, I tell you what, that idea that having a debate is dangerous is itself dangerous.
So final thought on, you mentioned that there's you think the consensus emerging of the lockdowns being very costly, not done anything. I'm happy to hear that because I believe that's true. And we have a lot of evidence, that people like you and me and others have been putting together on this, but would you say there's a consensus arising on that or is something that,
well, I mean, I think
I haven't necessarily feel that way yet.
I mean, I think scientists will be debating this and economists will be debating this for a long time. But I think in the population at large, it's starting to form, right? And you can see this with the mass protests around Europe, right, over the vaccine passports and lockdowns. You can see this in the United States where large populations just basically flouting COVID law or COVID policy, and they're openly mocking it. Like how many times have you heard the joke about people walking into restaurants? You put the mask on to walk to the table because the COVID spreads when you walk, and when you sit down, you can take it off, right? Because the COVID doesn't spread when you're sitting down. I mean, the population understands that's theater, right? And so I think in the population at large, we're seeing a turning. And I think it's inevitable. And so, and it's because of the facts, right? That like the population at large sees that these lockdowns have harmed them, that these restrictions aren't doing very much other than causing harm. Now there's still like, parts of the population that still are gripped in panic, but it's increasingly in smaller and smaller groups of people in blue enclaves that are still attached to this. Much of the population is done with the epidemic. The vaccines actually have done an enormous thing. Like they've reduced the risk of severe disease very sharply. We have monoclonal antibodies and other treatments that are quite effective if you should get sick. You have fantastic these like rapid antigen tests you can take at home. So when you go visit grandma, you're not infecting her. I mean, lots and lots of tools that the population at large is discovering, while at the same time there's still groups of people in the scientific community they're going to be, I mean, you know, when you have a policy so destructive as this, pushed by the smart people of the world, the smart people of the world are not going to readily admit that they did such damage, even though they did. And I'm not expecting that. So Carlos, don't look for that.
Okay.
look instead to the population at large.
Absolutely. Jay, thanks so much for joining us, and thanks so much for your work in the past 18 months or so.
Thank you. Take care, Carlos.